Hello everyone, I would like to welcome you all. It's pretty late and it's the last session, I guess. Thanks for participating, and I would like to thank the organizing committee, especially Dr. Mesut, and I would like to thank the co-presidents. Thank you for inviting me. I will be talking about new psychopharmacological treatments in addiction. It's a wide range of subjects, so I will be wrapping it up quickly. This is my outline. I will be talking about alcohol, cocaine, and opioids, because the others actually don't have treatments that cause positive results, end up in positive results. Well, we have indicated and non-indicated treatment options in terms of alcohol, and they all, I think, combined with psychosocial therapies, we have positive results. And after the detoxification treatment, our target is to limit and prevent the reusage of alcohol. I will be talking about disulfiram. Its effect mechanism is aversion-based pharmacotherapy, and it causes accumulation in acetaldehyde in body, and it causes toxic effects, and it has a very negative effects on the liver, on the patients. And we have some psychiatric pictures like delirium, psychosis, or mania. And if you do not give information to the patient about the treatment, then it can cause even in mortality. We have some anti-craving medications. We have naltrexone and nalmefene. They are both opioid receptor antagonists. The difference is nalmefene is related to the pain, and it does not much negative effect on liver when compared with naltrexone. The naltrexone's negative effect on the liver is more commonly seen. I think 50 milligrams is enough. Well, acamprosate is a glutamatergic antagonist treatment. Well, the difference is it's more about the stimulating trigger process, and in acamprosate it's more about the relaxation, and if the severity is more, then we see more negative results, and after the treatment we see that the effect is still continued. Well, in terms of naltrexone and acamprosate, we have a comparison here. We have a meta-analysis. Well, acamprosate is about full sobriety, and naltrexone is about heavy smoking. And this is an option of combining both of them. And we have different effect mechanisms, and the target is the neurotransmitters. The combination is safe. Well, when the combination is more effective when compared with the single usage of acamprosate only. This is the combination usage. When it comes to the non-indicated drugs, if there is depression, mild or severe depression, SSRIs can be used, but if there are no depressions, then it's not that effective. And fluoxetine was the most commonly used one, and I think data is not that reliable, and when we see the early onset, we see more negative results. And buspirone is a partial agonist of 5-HT1A. It shows positive results, but we do not have a reliable data too. We have some anticonvulsant medications. Naltrexone was found actually effective in the early onset. It's effective in terms of alcohol dependency. If the antipsychotics are used for alcohol dependency only, we see quetiapin's positive result, especially if it's used early onset, but it's not verified with the subsequent studies. But I think it has a indirect effect, and because of its effect mechanism, I think it has positive results, especially in low doses like 15 milligrams. And when compared with naltrexone, it provides sobriety more, but in 30 milligram, it's not that reliable. Well, we have some anticonvulsant, we have some medications called varenicline, and this is a meta-analysis of topiramate, but actually this drug was not researched for the usage of alcohol dependency, alcohol addiction, and it has very good results in terms of sobriety, have smoking, GGT. And it's important to note that we have some paresthesia. It can have negative effects on cognitive functions, and I think 3000 milligrams is enough. And this is a review of Payne et al. And when compared with placebo, it actually decreased the usage of the alcohol, and it increased the sobriety. And we use oxcarbamazepine, and it has very good effects, and especially in sea level, it has very positive effects. And it can actually make the other drugs functions more faster if it's used in high doses. If there's a comorbidity like bipolar disorder, then it's more effective than naltrexone. But in low doses, they have similar effect mechanisms with naltrexone. Gabapentin is a promising treatment option, especially in anxiety comorbidity cases. We have positive results, especially if we have SSRI-resistant PTSD. The alcohol dependency is decreased, and if we combine with naltrexone, then we have positive results. It has also positive results on sobriety and heavy smoking. In Cochrane, it's seen that it's effective in terms of decreasing the heavy smoking rate, and we have a editorial to be published, but it's shown that the results are not that positive, especially when compared with the fast-released one. The extended release, if it's used for 1 milligram, it's not effective. But pregabalin is effective in anxiety, and in actually it has a high potential to be used in different ways. And if there are patients using for example, his mother's drugs, we have some negative effects. These are the cases. Valproic acid is about bipolar disorder. Baclofen is more commonly preferred in French, and it has a very high sobriety rate when compared with the other drugs in the market, and it actually increases the days of sobriety, while low doses are more efficient than high doses. In the onset, if there is heavy smoking, it's more efficient. Well, varenicline is about a smoking treatment. We have 7 randomized controlled trials, and this is the review. And it has actually good results on alcohol craving, but it's not effective in terms of sobriety, and the results don't change in terms of the smoking rates. Now we have cannabidiol. I will be talking about this in my presentation tomorrow in detail. This is the latest review. We have a few studies, to be honest. Well, this is a systematic review, and CBD is well tolerated, and it has good results. Well, when it comes to cocaine, actually none of the drugs are FDA approved, and topiramate reduces the use and cocaine cravings, and when compared with naltrexone, disulfiram actually inhibits dopamine beta hydroxylase, resulting in an excess of dopamine and decreased synthesis of norepinephrine. And modafinil, actually it increases the date of sobriety, and it reduces the cocaine craving. We have vanoxerine constam. It's a specialized formula for cocaine, but I'm not experienced. Maybe in special clinics it might be an option. Well, there are no studies regarding this, but I know that it's used in many of the countries. When it comes to the opioid disorder, well, we have a combination of buprenorphine and naloxone, and we have deeper forms of buprenorphine and naltrexone. And naltrexone is not efficient when it used by hypoglottis, but if we use it with injections, then it's effective. So if opioid is used with medication, it blocks the receptors, and if we use it with buprenorphine, then we do not see the effect of heroin. We actually need to wait for some cravings, because if the heroin is still on the receptors, then buprenorphine has an antagonistic effect, and then we can see craving effects. Well, it has a film form, and it has a bioavailability, high bioavailability rate, and it tastes better. It has a batch number on it. It's legally more advantageous, and the children cannot use it. Well, the study shows that in terms of using it drug abuse, and we do not have a significant difference between two. Well, we have a implant form of buprenorphine. The treatment lasts for 6 months, and the FDA approves for 1 year treatment. And this study shows that, I won't give much detail, but I think it's interesting. There are two groups. 4 of them are implanted, and the other one uses it sublingually. We have 2 groups, and in the follow-up, after 4 months, the implant form is more effective by 87%. But we have another form of buprenorphine is called XR. It's get approved by FDA in 2017. It's used subcutaneous, and I think it's the most feasible form of treatment. We have long effect naltrexone. We use it in our clinic too, and we have the long eluted naltrexone. In the antagonist treatment, it's located in the receptor. Naltrexone is located, and if the patient gets heroin or uses opioid, then the heroin's effect is not seen. As in alcohol, the cravings triggered by stimulation is decreased thanks to naltrexone. So the recurrence rates are prevented. The disadvantage is that before the treatment, the 7 or actually 10 days of sobriety is required, and it's challenging for patients. We use symptomatic treatment, but I think it's very challenging for the patient, and this study suggests that when compared with the sublingual one, the extended release one looks more disadvantageous. But when the induction period is not seen, and I think the rates are similar to each other, because in the induction period, I think the success rates are by 94%, and I think the onset period is the most important one. Nalmefene is another extended release one. It's indicated for alcohol use in Turkey. Well, without being in a risky environment, like 2 hours ago, the patient should use it immediately. It actually prevents the pleasure from the alcohol, and I think it's more suggested to the opioid usage. It's not FDA approved yet, and actually we don't have much studies about it. But lastly, vaccines are important. This is a long-term study. Vaccines are studied for a long time. Well, we have some antibodies, and they are binded, and we have a high molecular structure, so they cannot get an access to the brain. It's not effective in terms of craving, but it can be effective in usage and preventing the relapse. But the important thing is to constitute sufficient antagonists. Thank you for your participation, and thank you for your attention.